Good morning. Going on with the surgeries of gynecology, today we'll be dealing with the vaginal operations done for pelvic organ prolapse. So the operations to be discussed today are Fothergill's operation, vaginal hysterectomy, and pelvic floor repair. I assume that you have already gone through the topic of pelvic organ prolapse and some of the surgeries have already been discussed. So whenever there is a pelvic organ prolapse, it needs a reconstructive surgery. That is, once the various organs of the pelvis have prolapsed, they have to be brought into the position in which they were before the prolapse occurred. So for that, the reconstructive surgeries has to be done. So, and this usually is a combination of procedures to correct the multiple defects which occurs during the pelvic organ prolapse. And the most commonly performed surgeries for uterovaginal prolapse is vaginal hysterectomy with pelvic floor repair. So, and route of the surgery for pelvic organ prolapse is mostly vaginal, but other routes like abdominal and laparoscopic surgeries have also been tried for pelvic organ prolapse surgeries. So whenever we are dealing with pelvic organ prolapse, that organ is divided into different compartments, that is anterior, middle or apical, and posterior. So different surgeries are there for the different compartments. The anterior compartment is usually cystocele and to some extent it is urethrocoele. And among the cystocele, the usual defect is a midline defect or anterior cystocele. In this diagram, we can see the pelvic supports which are there, and this is the thing from anterior to posterior. And this here, the arcus tendinous fascia pelvis is also there, and pubocervical fascia has been shown over the levator ani. So whenever the midline defect occurs, then the cystocele is in the anterior cystocele or the midline defect is there. And this defect is in the pubocervical fascia, and usually the surgery done for this is anterior colporrhaphy, and sometimes site-specific repair surgeries are also done for this. The lateral cystocele entails a paravaginal defect. That means, and it is due to vagina detaching from the arcus tendinous fascia pelvis. Here it has been detached, and you can see the defects, the lateral defects there, and for this defect, the paravaginal repair is to be done, which will be coming to later. And going posteriorly, the middle or apical compartment. The apical defects can be of three types. That is, one is the uterine prolapse, then there is enterocele, and then vault prolapse following hysterectomy. And for all these surgeries, usually the vaginal route is preferred. Going further posterior, that's a posterior compartment, that is rectocele. Here you can see the rectocele, that is the middle third of the posterior vaginal wall, and when it prolapses, that is rectocele. And here is the deficient perineum. There's a pyramidal structure that is deficient, and here the portion between the introitus and the anal canal, if there is a deficiency over there, then the deficient perineum it is called. So coming to the various surgeries which we are supposed to be discussing today, this Fothergill's operation, also called as MANCHETER'S operation. Though it is not much used nowadays, still it can be discussed so that we can discuss further surgeries related to this. And this is a conservative procedure designed to correct the uterine descent associated with cystocele and or rectocele, where preservation of the uterus is desirable. And most common cause of pelvic organ prolapse in young women is because of the pregnancy, especially because of the childbirth during vaginal delivery, because of the traction of the cardinal and uterosacral ligaments during childbirth. The supravaginal portion of the cervix elongates and contributes to this descent. So, as obviously the indication is pelvic organ prolapse, where the preservation of reproductive function is to be considered, and when symptoms are due to vaginal prolapse associated with the elongation of the supravaginal cervix. So the supravaginal cervix is elongated and then there is a uterine descent, and that's why one of the components of this surgery is amputation of cervix. So what is the selection of the patients? Patient should be young, there should be elongation of the cervix, patient should be desirous of conserving the uterus, and there should not be any other pathology which demands removal of the uterus, and then there should be significant vaginal prolapse. During vaginal delivery, some amount of prolapse may be there, but if it is not disturbing the patient or it's not significant vaginal prolapse, usually we ignore that. So one of the components of, that's why one of the components of requirement for this FOTHERGILL'S operation, that there should be a significant vaginal prolapse. So essential components of FOTHERGILL'S operation is amputation of the cervix, then the approximation of the cardinal ligaments in front of the amputated cervix in order to shorten the ligament, so that the ligament which has been elongated due to stretch on that one, here it is shortened and then it is sutured on the anterior part of the cervix, and because the cystocele is there usually associated, and the anterior colporrhaphy is done, posterior repair is done in case it is required. So the procedure, preoperative preparation is as for any major surgery, and one single dose of antibiotic prophylaxis is given within 1 hour of surgery, means within 1 hour before the surgery, and regional anesthesia is preferable in these cases. Dorsal lithotomy position is given, bladder is catheterized so that it is easier for the surgery to be done, and pelvic examination is again done under anesthesia to ascertain the extent of the pelvic organ prolapse, the size of the uterus, direction and mobility of the uterus, and if there are any adnexal mass or anything, so that it is reassessed again during anesthesia to plan for the type of surgeries to be done. So, and dilatation of curettage is usually performed, which we discussed in the last class, and enough dilatation has to be done because that will come to later why enough dilatation is to be done, and curettage is done, and that is taken, endometrium is taken for the sent for the histopathological examination. Then the length of the cervix is ascertained and the level of the amputation is decided upon. So we have to leave 2.5 centimeters of the length of the cervix behind so that it is not unduly shortened. So that's why the length of the cervix has to be ascertained before proceeding for further surgery. Now then there is what is called as FOTHERGILL'S point. 4 Alice clamps are placed in that FOTHERGILL'S point. First is just below the external urethral meatus over here. Then at the posterior fornix in the midline, and then there are 2 lateral points are there, so that when they are approximated would result in a vagina of appropriate depth. So depending upon the amount of prolapse, these lateral points are to be discussed, because this portion will be, the vagina of this portion will be removed. So this will be a rhomboid shaped incision when we are joining these points, and the vagina over here is separated from the underlying tissue. After this vagina is separated from these 4 points, then the vesicocervical ligament is cut, which is usually over here, and then the bladder is pushed up. The cardinal ligaments, that is transcervical ligaments, are clamped, then cut, and with the straight clamps, then cut and ligated. We can see the cut and ligated over here. And then when both the Meckenroth's ligaments are clamped, cut and ligated, cervix is amputated at the desired level so that the 2.5 centimeters length of the cervix remains. Then the cardinal ligaments, which are cut, are brought forward and approximated in front of the cervix with sutures. And then the anterior colporrhaphy is performed if there is a cystocele, which is usually there. So this is another diagram showing the McEnroth's ligament, which are sutured in front of the cervix. This is a transverse section of the cervix. Here you can see that both the McEnroth's ligament have been cut from here, and then they have been brought in front and stitched in front of the cervix. These are the two uterosacral ligaments which can be seen. So once this is done, the anterior part of the vagina is closed vertically. Then the amputated end of the cervix is covered by vaginal mucosa, which is there left behind, using what is called as Sturm-Drauf suture. So what is Sturm-Drauf suture? We'll be coming into the next slide. These are two sutures are taken through the vaginal wall at 12 o'clock position and the 6 o'clock position, and the ends are left long. So the two ends of the anterior sutures are taken over the anterior cervical lip through the cervical canal to emerge at the two FOTHERGILL'S points laterally. And the same thing is repeated posteriorly. Here we can see the sutures being tied, and then this goes inside and then comes out on the lateral points. These are the lateral points which are seen. So once it goes inside, and then once they come out of the lateral points, then they are tied together. So ultimately this will be the picture. This is the posterior cervical lip, which has been, the suture has been tied over there. So once this is the posterior, then the anterior, and little bit this vaginal walls which are there in the lateral part, they are stitched with each other. So this completes the Mancheter's repair, and after that the vagina can be packed by betadine gauze, so that if there is any amount of little vaginal bleeding, that is stopped. However, there are some disadvantages and complications of FOTHERGILL'S operation. It is high rate of recurrence is there. Then this can lead to cervical incompetence. If you do too much vigorous cervical dilatation, then there can be cervical incompetence, which later on may result in recurrent miscarriage or preterm labor because the cervical canal is widened. On the other extreme, it can also lead to cervical stenosis. If your repair has not been proper and the cervical canal is stenosed, then this can lead to dysmenorrhea. In extreme cases, it may also lead to hematometra, and sometimes this can cause infertility. And because we cut the cervix, there can be changes in the cervical mucus quality, both from the trough surface as well from the cervical canal, and that can also lead to infertility because of the cervical origin. So to obviate these problems or these disadvantages, a modification of the same surgery has been done, which is called as SHIRODHKA'S extended Manchester or vaginal sling operation. There are certain modifications of the same surgery in which those disadvantages or complications are minimal. So it's a modification of FOTHERGILL'S surgery. There is no cervical amputation. That means cervical amputation is avoided. Here, instead of the cardinal ligaments, we take the uterosacral ligaments. They are isolated. That means the uterosacral ligaments are cut near the cervix instead of the cardinal ligaments, which was done in the Mancheter's operation. So then they are isolated to form slings, which are crossed over one another and stitched together in front of the cervix. We will not be going into the detail of this. I will show the diagram of the same. So in this one, you can see the uterosacral ligaments which are there posteriorly. They have been brought anteriorly, crossed over one another and stitched in front of the cervix, and no cervical amputation has been done. So this is the transverse diagram of the same. McEnroe's ligaments are intact. The uterosacral ligaments have been cut over here, and the uterosacral ligaments, they have been brought in front of the cervix. They cross over each other and they are stitched in front of the cervix.